Um, I'm Parya Saberi. I'm faculty at UCSF at Division of Prevention Science, and I'm so excited to be joined here by my colleague, Dr. Jennifer Cocohoba, who's a professor and vice chair for faculty development in the Department of Clinical Pharmacy at UCSF, and the co-vice dean of Clinical Innovation and Entrepreneurship at School of Pharmacy, which sounds so exciting and interesting. And she has served as the clinical pharmacist for the UCSF Women's HIV program since 2004. And her research interests really lie at the intersection of medication adherence, implementation science, and medication use among people with HIV. So on a personal note, I have known Dr. Cocohoba since 2005 when I first moved to San Francisco. So it'll be almost 20 years. And we've conducted several studies together. And little known fact about Jennifer is that she's a great connoisseur of art, dance, food, and wine. And that's why we're friends. And I'm so honored to call her my friend and colleague, and so excited to hear about her presentation on preparing pharmacy-based delivery of long-acting injectable antiretrovirals. Dr. Cocohoba, please take it away.
I want to thank everyone for attending today out of your busy day, and mostly thank the organizers of the town hall, including Dr. Saberi, who I have known now for almost 20 years, for allowing me to present my research, which I will have to say is work in progress, almost finished. So we're just wrapping up the last parts of this study, but I'm excited to share some of these data with you. Our team members include several persons you may know at UCSF, including Dr. Saberi herself, Dr. Kuka, and Mr. Sigwa. We're also composed of study team members at Nova Southeastern University in Florida. Dr. Hester's over at Auburn University, and Dr. Udiani is over at Texas A&M Corpus Christi, and you'll see how those team members are relevant to the design of the study as we move forward. I think I don't have to explain to this group how excited we are about long-acting antiretrovirals, the majority of which right now that are available are injectable. We all know what the potential benefits and the promise that's held by these long-actings. We're looking at the opportunity for fewer pills, perhaps improved adherence to minimize difficulties and coordination for patients of making it to the pharmacy, the clinic, and lab, and all these places. And what we're ultimately hoping for, the big promise that these long-acting antiretrovirals hold, is for controlling viral loads in a way that reduces HIV transmission, that moves us closer to ending the HIV epidemic. The first antiretrovirals that were long-acting injectables were approved by the FDA in 2021, and we're now 2 years plus into the thick of more long-acting injectable antiretrovirals that have been since approved by the FDA for both treatment and prevention. And it has been a climb, I think, with regards to implementing these new treatments and new technologies into our daily workflow and our practices. In the published literatures, the first implementation studies that were conducted with these long-acting antiretroviral injectables were the customized studies, which were conducted by the company. These were phase 3B hybrid type implementation effectiveness studies, and these were large studies. So this was customized, was an 8-clinic program where they launched long-acting cabotegravir with long-acting rilpivirine, and they surveyed them over a year, both the healthcare providers as well as the patients. And you can see some notes about these studies. In the customized study, there were 8 clinics, and they were all different kinds of clinics. So there were federally qualified health centers, there were private practices. The model differed quite heavily across the different sites on purpose. This is an implementation effectiveness study. And the major findings of these studies were that long-acting injectables were feasible. They were able to be administered, that the implementation really peaked, I guess, around 3 months in for these clinics that were excited and raring to go with these, and that things that providers were worried about, like patients making their appointments. At that time, long-acting injectable was administered monthly, so they were highly worried about people making their appointments, and really over the end of the study, much less worried because they saw that people did make their appointments. Another thing to note in these studies was the role of pharmacists or pharmacies, typically pharmacists in these clinics, because a lot of these clinics were multidisciplinary programs. And so in the big customized study across the 8 clinics, there was not that much of in-depth mention of the role of the pharmacist. There was one mention where one clinic had a pharmacist in charge that was added to a multidisciplinary team huddle to help facilitate implementation of the long-acting injectables within their program, but not much else mentioned in the customized study. We've now since had people publishing real-world experiences with launching long-acting antiretrovirals in their clinics, one here at home at San Francisco General with Dr. Christopoulos. This was over at Ward 86, and I think people may be familiar with this cohort where they described the first 50-ish persons that were initiated on long-acting antiretrovirals. That was actually a unique population of persons who were both undetectable, which is the current FDA labeling for the medication that was available at that time, cabotegravir with rilpivirine, but also some of them had detectable HIV viremia, which is not, I guess, the normal cohort of persons that you would launch these types of medications in. And this program was described for that the patients had done very well in this highly supported multidisciplinary program. They did describe the role of the pharmacist over at Ward 86, which is very instrumental in getting this program up and running. That's Dr. Wachowski and her team as well. So the pharmacist was highly involved in assessing patients for eligibility and educating patients and really helping the clinic procure the drug, which is a challenge in and of itself. Other clinics have also described, so in the Collins paper, this was a clinic in the South, Ryan White funded, Atlanta, Georgia, approximately about the same number of patients. So that were screened, although a much fewer number of patients actually initiated on long-acting antiretrovirals. And again, here they describe the role of the pharmacist, which is really very technical. I think for this multidisciplinary clinic, the pharmacist was responsible for coordinating health information technology, creating work queues, filling out databases, and then working on the billing and reimbursement. And then most recently, our colleagues, Dr. Hill down at UCSD, published their experience, which is a pretty large cohort of folks that were initiated on long-acting antiretrovirals. And similar to the other real-world reports that have been published for implementation, the pharmacist was deeply involved in the process of facilitating long-acting antiretroviral therapy in these clinics, reviewing eligibility, educating patients, et cetera. So I think we have these emerging studies. We have the large customized implementation effectiveness study, and now these real world reports at different types of clinics, San Francisco General's Ward 86, the Academic Medical Center down at UCSD, and then the Ryan White funded clinic in the Deep South, basically, very different models, launching implementation of their programs and sort of describing how they did it. So, these studies suggest that it's feasible to implement long-acting antiretrovirals in clinics, just like the customized study suggested. It works. I think what we're now reaching is the question about capacity. So if we have more persons that are interested in long-acting antiretroviral therapy, will programs be able to expand and sustain the number of persons that are and the support systems that are needed to get all these persons on these medications? And potentially, if there is increasing desire for long-acting antiretroviral therapy, that it is really important at this point to consider these differentiated care models and alternative care models to help expand access to these medications. I think a lot of us also recognize that community pharmacists, they're important. They're an important part of the care team for a person living with HIV. And most people also recognize the pharmacies are everywhere, right? Most people within the United States live within 5 miles of a pharmacy. So I think the assumption has been made that eventually community pharmacies will be a place where persons can receive and even have administered their long-acting injectable antiretroviral therapy. But that promise has not yet been realized. It's early, and little is known at this time about all of the attitudes of all the key players, patients, clinic staff that would be referring, and the pharmacists and pharmacy staff members themselves about having long-acting antiretrovirals injected within their community pharmacy walls. So that leads to our research project today. And the aims of our study are to evaluate pharmacy staff, clinic staff, and patient attitudes towards administration of long-actings within community pharmacies, really to focus on identifying real and perceived barriers and facilitators for implementation within community pharmacies. And ultimately, what we'd like to do is use this information to develop more practical guidance to assist pharmacies who want to implement long-acting antiretroviral administration in their current settings. So this is our study design. We are in almost completed conducting a convergent parallel mixed methods study. We have included persons who are older than 18. Our 4 sites were hinted by our co-investigators. So we've got sites here in Northern California, primarily the Bay Area. It's Eastern Texas, where all the cities are. So Corpus Christi, Dallas, Fort Worth, etc. Central Alabama, it's Montgomery, around that area. In South Florida in the Miami, Hollywood area. We've requested that persons who are enrolling in the study who are either clinic or pharmacy staff work at a place that serves at least 5% of their population of persons with HIV, so that they have some familiarity with the medicines, the patients, the patient care. And for persons with HIV enrolling in our study, we'd requested that they are either on or eligible, at least eligible for antiretroviral therapy, so they have some interest potentially, or no interest, it really depends on the person, on long-acting antiretrovirals. Because we have 4 different sites and the IRB had to be reviewed by all the different sites, there's slightly different recruitment methods depending on what was allowable at each area. All sites were allowed us to distribute recruitment flyers, and so that was sort of the mainstay, whether they were physically distributed or electronically distributed. Some of the sites had access to persons with HIV because they practiced within clinics, and so they were able to recruit locally for patients kind of using those flyers or through word of mouth. And really we were seeking purposive sampling. People utilize their networks to look for persons who would be good candidates and have clear and helpful thoughts, attitudes, and opinions on this intervention within community pharmacies. So we had our survey followed by a semi-structured individual interview. We conducted our survey via REDCap, as well as the consent form was on REDCap as well. We created 3 separate semi-structured interview guides. One was targeted to each stakeholder group, and the questions were tailored to be appropriate for that stakeholder group. And all questions are really formulated based on the Consolidated Framework for Implementation Research, the CFIR. At that time, there was the older version. A newer version has come out since then. These were audio interviews, but they were conducted via Zoom. We just had everybody shut off our videos, or we dialed out to people and we transcribed and loaded the interviews up into Deduce for analysis. It was primarily at this point, for the survey, descriptive statistics for all of the different baseline characteristics, and we're conducting a thematic analysis with the interviews. So here's a sample of the codebook that we have created, and you can see here they're fairly straightforward concepts such as just barriers, attitudes, pros and cons of the intervention. The needs column, which has a lot of subcodes to it, is based on the CFIR. So you see things like human resources, leadership, kind of policy, space, training, etc. Those are concepts that are aligned with some of the CFIR constructs. We were also, as we went through the 8 meetings that it required to refine the code book with the coding team members, we also saw some emerging data around relationships. That was interesting. We wanted to capture that in the data. So relationships between the different stakeholders, whether it was clinic pharmacy, patient in their clinic, patient in the pharmacy, and also this concept of trust that we thought was really important to capture as well. So I present to you today our current results. We are at an N of 61 right now. 6 of my transcripts are still pending transcription. They're in the hopper for transcription. So today what I present to you is the 55 persons who have completed, the data for the 55 persons who have completed both parts of the study. So have completed both the survey as well as have their interview reviewed and coded. And so we are at 14 pharmacy staff, 20 clinic staff, and 21 persons with HIV who have enrolled in the study. You can see the numbers here. I think really what we're pending is that transcription of those last 6 interviews, and then continuing to still really pursue enrollment of persons with HIV in our Texas site as well. Main findings for some of the basic demographics, you can see here that our persons with HIV who enrolled in this study are of an older age. I don't want to say that they're not elderly, but they are on the more experienced side of life at 53. We also have a good proportion of persons who identify, who are female at birth, who have enrolled in the study, at least across all stakeholder groups. And then some of the other thing that we noted from our studies, we have a strong proportion of persons who have identified as persons of color across all stakeholder groups as well. For our persons with HIV, you can see here some of their characteristics. Most of the persons who've enrolled in this study have been living with HIV for more than 10 years and who take a lot of medications. So, on average, their total number of medications is 5, which I think is in line with polypharmacy studies with persons with HIV. All of the persons, as by eligibility, were currently taking antiretrovirals. And some interesting pharmacy-related issues for our persons with HIV is that most of them attended a physical retail chain pharmacy as the way to obtain their medications, although there was a good chunk of them who also received their HIV medicines by mail order pharmacy. Again, kind of the idea, most people, because it was interesting, even though a lot of persons had medicines from a retail or chain pharmacy, the majority of persons had their antiretrovirals delivered or mailed to them. So there wasn't a direct correlation between I use a mail order pharmacy and I get my medications by mail. It seems like people were receiving delivery or mail through other pharmacy methods as well. Another interesting point to note is that the majority of persons in the study went physically to a pharmacy at least once every 2 months. For our persons with HIV, we had a little continuum of persons, kind of where they were on the interest in injectable long-acting antiretroviral therapy continuum. And we had about a third of our persons with HIV who were already on long-acting, and so they offered that insight. And then a strong chunk of persons who were interested, so they definitely are probably going to consider trying long-acting in the future. And then we had a small number of persons within that patient group who were much more on the fence or really just, no, this is not for me. So if you wanted to take a look at our clinic and pharmacy stakeholder group, you can see here, again, a fairly experienced group, spent 6 years or more at their organization, the majority of them. And also, at least particularly for the clinic staff members, many of them had been serving persons with HIV for a long time, for over 10 years. It's much more distributed amongst the pharmacy group with regards to their experience serving persons with HIV. The clinics that we surveyed, a lot of them had kind of cared for less than 50 persons per week. Again, sort of variation across both of those. Some numbers there about kind of prescriptions or patients seen per year. For our pharmacists, it was kind of 50-50. So pharmacy staff members, they were either just pharmacy staff, about half of them were actually managers, and so we're able to provide that kind of insight. And the pharmacies that we were able to capture for recruitment varied. So there were some clinic-associated pharmacies, there was a majority of retail or chain, your kind of regular community pharmacies, and a couple of independent pharmacies as well. Couple other things about our pharmacy and clinic staff members. You can see here with regards to their self-rated knowledge about long-acting antiretrovirals. Most felt pretty middling. So they're like, oh, I know something, or felt like moderately knowledgeable about these medications. And then just a few of them, more so in the clinic staff group, felt like very familiar and comfortable with these long-actings. And you can see here also descriptions of the various roles that they might play. A lot of people working directly on eligibility. Obviously, a lot of the pharmacy staff members we surveyed would imagine that they would be responsible for actual dispensing of the medication. You can see here some of the varying level of experience for persons actually getting long-actings injected by their organization. One of the key outcome measures we looked at were on 3 implementation scales. These were the acceptability of intervention, appropriateness of intervention, and the feasibility of intervention through the AIM, IAM, and FIM scales. And these are 3 separate scales that have sometimes been used in aggregate. Each of these scales contains 4 questions and assesses each of those things: acceptability, appropriateness, or feasibility. In this case, for community pharmacy administered long-acting antiretrovirals. The maximum score you can receive for any individual scale is 20, because there are 4 questions, 5-point Likert scales. The minimum score you can receive is 4. And then the maximum composite scale would be a total of 60. I think what I want you to take away from this particular graph is how close everything is. So high and close. So for acceptability, not much variation between pharmacy, clinic, and persons with HIV. Same for the IAM and FIM. What appears to be overall is that clinic staff were much more optimistic, enthusiastic about the acceptability, appropriateness, and feasibility of community pharmacy administered long-acting ART. Patients and pharmacy staff members kind of more the same, but no statistically significant differences between all the groups, at least for the composite scale. I think the most interesting part of the study has been really understanding attitudes towards community pharmacy administered long-acting medications. And so you can see here the patients in green, the clinicians in blue, and the pharmacy staff members in pink. And so we're getting attitudes that were generally positive across all the groups, with some expressed trepidation mixed in with that. So patients say things like, yeah, if the pharmacist is qualified to give me a shot, yeah, give me a shot. Clinicians, I think it depended really for clinicians. Their attitudes were generally positive, with some trepidation about their experiences with community pharmacy. So very supportive of the idea, like anything that helps patients receive appropriate care, anything that makes it easier for the patient, as long as it's done in a safe way, I'm 100% in favor of. But then some clinicians perhaps were a little bit more savvy or had different experiences with community pharmacies that made them more hesitant. So one clinician in Florida said, I'm hesitant because of where community pharmacy is for the most part right now. Pharmacists also generally had positive attitudes, about the idea of administration. From an adherence perspective, I love this. And also express their worries about it. So I'm concerned about pharmacies administering them, not so much the dispensing, but more administering, and then called out some specific types of pharmacies that they were more worried about, sometimes chain pharmacies, most often chain pharmacies. What we're finding across interviews is this idea that administration of long-acting injectables within community pharmacy is certainly good in theory. There's all the things that you would expect people would be excited about were expressed in the interviews, including benefits to access, benefits to convenience, and benefits to cost to the patient, particularly. Like, pharmacies are available on every corner. Patients can choose to get where they're shot. Pharmacies are open later hours than clinics and open on weekends. And hey, there's no copay needed at a pharmacy. It's going to be cheaper for patients. I think what was really revealing was to contrast some of these exciting opportunities with some of the trepidations and hesitations that some of the pharmacists had. So, in direct contrast to saying, hey, there's a pharmacy on every corner, pharmacists or pharmacy staff members said, well, maybe certain pharmacies would be more suited, like specialty pharmacies. Not all pharmacies can do this. Or with convenience, yes, pharmacists themselves said, yes, we are open later and open on weekends, but this would work best if we had an appointment-based system like we do for vaccines. And same with cost. The idea of not having a copay was in direct contrast to the concerns that pharmacists had about not getting reimbursed for clinical services and the idea of trying to make something sustainable for them. This is a very busy slide, so I apologize for this as we're still trying to analyze the raw data for the interviews. There's a lot of it. Certain facilitators are emerging from our research. Some things that are potentially facilitators for community pharmacies administering antiretroviral is just this general idea of positive regard for pharmacists in general. I think clinicians, patients have had some good experiences with their pharmacists. So when clinicians said it, I think patients feel comfortable with these community pharmacists. They are trusted providers. Or patients said things like, oh, there's some good pharmacies out there. They've got good attitudes. Everyone's friendly. And I think another thing that really emerged as a facilitator was the recent experience that a lot of people had, clinicians and patients, with pharmacies administering COVID-19 vaccines. So multiple times people talked about their experience and how that might facilitate their attitudes around getting a different kind of intervention within the community pharmacy. One clinician said, I have full confidence. I mean, pharmacies do all kinds of injections all the time, flu, COVID, all the regular vaccines people get, whooping cough and all that. I have full confidence they'd be able to do that. Even pharmacists gained confidence through their experience with COVID-19 vaccinations. They were like, well, I've done this, I can probably do that too. One pharmacist said, it wouldn't interrupt me any more than a vaccine would. I take a vaccine out, or in this case, it'd be an injectable, and I would sit it. I'd continue to do my workflow. I'm just making sure it's sitting there for 15 minutes. I go back, I draw it up. It's not like I stand there and stare at it. It's not any different than a COVID booster as far as timeline. Relationships were a big facilitator for the potential for injectables, long-acting injectable antiretrovirals at the pharmacy, and all kinds of relationships. It was relationships between the physicians and the pharmacies they work with, the patients and the pharmacies they work with. That's certainly obviously having a good relationship increased trust and confidence that a pharmacy would be able to administer. On the flip side, a perhaps more negative item that would be a facilitator for pharmacies administering was a sense of overwhelm that clinician staff had experienced. They were concerned about capacity. They were concerned about staffing. So there's my dog. One clinician said, I have a list of 50 patients that's waiting to start Cabenuva that we can't because we don't have the capacity in our clinics. So, basically referring to community pharmacy administered long acting, that would alleviate it and allow us to provide some of those services for them. The barriers that people express to administering long-acting antiretrovirals within community pharmacies are probably not that surprising. One of the biggest barriers, most commonly reported barriers, was the lack of space and concerns about privacy. Most of you probably walked into your own pharmacy and noticed the lack of private space to administer a ventrogluteal or expose parts of the body for another type of injection. So I think some pharmacies express the challenges of being able to modify their space to create private space is just not so easily done. Lots of discussion around staffing and being able to have adequate staff. Pharmacies were always experiencing staffing. That was particularly, I think, in the era of COVID and post-COVID, it has become worse, and pharmacies have discussed this. It's also taking a toll on us. Our team right now is aware of that, and they're working a bit extra, and it's a bit stressful at this time. Reimbursement, the barriers to reimbursement are very complex. I think managers have brought up really important and obscure concepts that people may not be aware of, such as the purchasing agreements they make with wholesalers, or their purchasing requirements through wholesalers, the ability to access certain medications from the manufacturer, even that is limited to some pharmacies, and the reimbursement for actually taking the time to provide this service. All of those things related are different items that are related to reimbursement and finances that may not be as clear to folks who don't live in the pharmacy world. And the last barrier that emerged was just, some mentions about training. At the time that we had initiated this study, the only long-acting injectables were administered by ventrogluteal or sometimes dorsogluteal injection. That has changed since then with the approval of new long-actings. But some pharmacies expressed concern about needing to train on this new technique of providing injections that were not going to be in the deltoid. I think one thing we're appreciating from all of the interviews is something that would seem to be a very simple intervention, take out a shot, give it at the community pharmacy, turns out to be much more complex from a treatment and prevention perspective. Some of the responsibility still lies with the clinic, and some responsibility then lies with the pharmacy. So participants expressed, not concern is not the right word, but just, I guess, interest in trying to better understand how responsibility should be divided, and had some ideas about, who is responsible for follow-up, who communicates what, how do we share information. Persons brought up the idea and challenge that we have disconnected electronic medical records, oftentimes between pharmacies and clinics. Unless you work in a closed healthcare system that has everything all together, you have to work between these, and that is one more barrier to communication. There was a lot of discussion around how we track patients, because this is not a one-time administration. We would expect this as an ongoing therapy. So how do you know when a patient has missed a dose? Who communicates? How is that information communicated? And what do we do? Who's responsible for following up with the patients? And it was interesting that clinicians and pharmacists and patients all had different ideas about who should be responsible for these aspects of care. Some of the clinicians brought up a unique complexity to the intervention as well, recognizing that when people come into clinic for their long-actings, that they're not just often getting their long-actings, they're getting other care pieces, whether it's primary care pieces, getting other services, having vitals taken, et cetera. And so there was some discussion amongst some clinicians about how, if long-acting injectables were to move locations to the community pharmacy, that the clinic may lose some opportunities to capture patients for other necessary clinical services. Oops. That's nice. All right, so there's, I think in conclusion thus far, and further data will help us solidify this. What we've discovered is that it's going to take some work to move the needle to community pharmacies. In general, we have positive support around the idea of pharmacy administered long-acting. There wasn't a person really who was like, no, this is a really terrible idea. But there was just a lot of trepidation, confusion, concern about how this is going to happen, all the details and the workflows and the reimbursement, et cetera. So I think people just had a really difficult time imagining how to do it all, and how to do it all within their own local context, much so, in a way that's systematic across areas. So I think the answer to that is that it's not. There is no one-size-fits-all model that's going to work for incorporating community pharmacies to administer long-acting antiretrovirals. Really, the optimal use of pharmacies is going to depend on what the local resources are. What is the community need? What are the clinics in existence? What do the clinics have already? And what, how do we best share these responsibilities in a way that works for a local system? And there is a lot of work that we need to do. I think there are just different areas that we need to attack at multiple ends to really make sure that when we do this, that there's opportunity for sustained success. We need to ensure that pharmacies have equal access to medications, from the manufacturer, from their wholesaler, in a way that doesn't punish their business models. Integrated tracking systems would be phenomenal to develop to facilitate communication, and really developing sustainable reimbursement streams can support the staffing that's needed to do this in a way that's scalable and sustainable. So again, in conclusion, generally there was an openness to having community pharmacists administer long-acting injectable antiretroviral therapy across different stakeholder groups, the pharmacists, the patients, and the clinicians. And there isn't, I think, a one-size-fits-all model. We do have an ideal pharmacy. I don't know if this pharmacy exists. There's a few, apparently, that exist because they're doing it right now, a very small handful. And these ideal pharmacies have existing strong relationships. They have the adequate staffing, they have private spaces, they have ways to communicate with their clinicians and their patients that are facile and modern, and they have methods, sometimes not related to the injections themselves, but alternative methods to ensure that there's financial stability for providing these services. We really do need to tailor these shape to community needs and whatever resources exist. And we do have a lot of work to be done to really integrate these duties across clinics and community pharmacies. So, I think we need to understand what are the responsibilities and how are they best shared? How do you share the tasks and facilitate those communication streams, whether they be through implementation champions, program leaders in both of the places. All of those ideas, I think, still need to be explored to give people options on how to create these programs in a way that works for them, utilizing their local community pharmacy resources and their local clinic resources. So that's all I have for you today. I'm happy at this point to take any questions.
Wow, thank you so much, Jen. That was wonderful. So folks have questions, if they want to put in the chat or just come off mute or raise their hands, however you'd like to do it. And as Kim, I was about to ask a question, but you go first.
Hi, Jen. Thank you so much. That was fantastic and so clear and really interesting. Full disclosure, some of us on this call are working on a similar implementation science study with clinics, including Ward 86 and a couple others. And I am wondering, and maybe this isn't something you know off the top of your head, and if not, I would just encourage you to do this analysis in the future. But I'm really curious about what the patients who are receiving long-acting. So you don't have a lot of patients who are actually on long-acting, but there are some. And I wonder if their opinions differ because they are actually experiencing these shots. And so it's interesting that just to remember that there are 2 shots, one in each side. And so I'm just curious about what people who've actually experienced the injections and their views on whether they would receive it in a community pharmacy setting. So if you have any kind of reflections on that, that would be great to hear.
I do. Thanks for your question, Kim. Absolutely. We have a really tiny sample of persons who are already receiving long-acting. I think from our little tiny analysis of 7, it has varied widely. I had one person who was like, there is no way I would receive these injections at a pharmacy. Whereas others like, yeah, people are like, yeah, it's fine. I could get and we're excited about it because they're like, oh, well, then I wouldn't have to drive an hour to clinic to go get my injections. So it was really, in our tiny sample, widely variable. And I think a lot of it was moderated by relationships with their clinics, So if they were highly attached to their clinic, makes sense, they'd be less attached potentially to their pharmacy and the clinician staff, and driven by practicality. So persons that were really struggling to make their injections, I think, were more open to other alternatives. But again, this is a really itty bitty little sample, and just kind of my reflections and observations.
Thanks, Jen. Any other questions, folks?
Hi,
Well,
Parya.
go
So
go
Ellen,
go.
go for it, Ellen.
Thank you. This is amazing. I have a few questions actually. So I'm curious, in San Francisco, is the model that you're planning for that people can go to any pharmacy, or is there a particular few pharmacies that have been identified? What's kind of in the plan?
Good question, because I am also working on San Francisco as well. The follow-up to this study will be a tiny demonstration project at a single pharmacy. And that's my area. I know Kim and group are working on other implementation models as well. All implementation models are welcome. I think we can use all of the help we can get. I think what I have discovered is that the barrier, the ideal would be that patients could go anywhere, right? That's the promise of having long-acting injectables. Oh, I could walk into this Walgreens over here, and then if I'm over in this town and I'm traveling, I could go to this Walgreens. That's the ideal. I think I'm uncertain whether that reality can be achieved very soon. And I think it's really the barrier is the communication streams, like how do you follow whether one was injected here and sort of who follows them if they're going to go to a different pharmacy over here. Like, what is the central place where you can log in and go, oh yeah, you're on time for your injection, or oh, you're late, who's going to call you? So I think my guess is what is happening right now is there are a small number of pharmacies across the United States. In our study, we managed to talk to two. There's another one that I'm aware of that it was not sort of in our study area up in Washington at Kelly Ross, it's going to start slowly. It'll start slowly with pharmacies that are more facile, like usually independent pharmacies are able to dictate their processes and policies a little faster. And then what we're hoping is that will spread. I think Dr. Saberi and I were part of NIH facilitated pharmacy meetings, really looking to push forward the ability of pharmacies to provide at least prevention medicines, long-acting and oral medicines. So I'm hoping it will spread. There are practical barriers. That was a really long-winded answer to that question, so I apologize for that.
Mm-hmm. Mm-hmm. I mean, are you considering working with CBHS in San Francisco, or?
I'm guessing, Kim, or you guys are working with CBHS, no?
Not yet.
Not yet, yeah. But I would imagine that would occur in the future.
I think so, but I think maybe I just want to pop in here is a question about who's actually administering the shots in a pharmacy setting, because these are not easy to administer. At least there was one quote that indicated that they're technical and they're difficult and they're below the belt. So do we even expect that it's going to be pharmacists who would be doing the injections, or would we really want to have a nurse on site? So what's happening in those other settings? Do you know?
So in the other settings, currently there are pharmacists administering the injections. There are business models that large pharmacy corporations have proposed, these idea of like basically having like a minute clinic within the pharmacy where they hire a nurse to administer. It is really interesting. In our research, while the pharmacy staff members expressed some trepidation about learning a new technique, there were also a chunk of pharmacists that were like, yeah, I can do that. We can do IM administration. It's just a matter of training. So I think it wasn't like I can't do that. It was more, okay, I need to make sure I get training to do that.
And have a space with a curtain.
Yes. So lots of stories about what their spaces looked like. So I think most people really didn't want to do it with just a curtain. Some had the luxury of private spaces, and then lots of really funny quotes from patients about their level of comfort of dropping their pants.
Jen, Lewis is also asking if there's any community pharmacies that are currently offering the injections.
Yes, so there are, at least what I am aware of. So there is a community pharmacy in Washington State, Kelly Ross Pharmacy, led by Elise Tung, that is currently administering injections. There is, I don't know whether to call this a community pharmacy, but there is a community pharmacy in Sacramento who is also currently administering treatment as well as prevention injections. That's Pucci's Pharmacy, Clint, and who is also looking to expand. They bought another pharmacy in Los Angeles, and so they're trying to get it over there as well. And then there is a pharmacy in Houston, which I don't think totally qualifies as a community pharmacy because they are a pharmacy inside of a medical office building. So they're kind of like a specialty pharmacy. And the pharmacists there are administering injections. There may be more, but those are the three that I'm aware of.
And so and along the lines of that, would you be able to just give us a quick glimpse of your next project, which I know is working with a pharmacy to start offering the injections?
Yeah, so we were really excited to be able to get an EHE supplement. So as the next step from this project, we're going to churn the 50 million pages of data we have loaded to deduce to actually try to create for the lack of a better description, like a manual of operations or a guidance document to like sort of a step-by-step in terms of how to launch your long-acting injectable antiretroviral therapy service. And so as part of the AHE project, we'll create that manual, sort of float it by in a focus group by practicing pharmacists to make sure it makes sense and is practical and hasn't missed anything, and actually test the manual in a local community pharmacy. TinRx has signed on to be our partner. So we're excited to work with them in there near the Castro.
Nice. Any other questions, folks?
Open to a comment?
Of course.
May I ask, were super small numbers, I realize, but were any of the patients in the HIV sample also people who were using drugs or are using drugs, and any differences between those folks and the others?
What a great question. We actually did not collect that information. So we did not collect substance use from our patients. But it is a really interesting and important group to understand their preferences and desires. I think that our colleague Morgan Philbin, who I know has presented here before, has done some of the preference work in the WISE as well, and that sample definitely has substance use records. I can't remember if she parsed that out.
Kim, do you want to offer your?
Yeah, sure. Jen, thanks also for telling us about your EHE project. Congratulations on that. In terms of thinking about if you have a need to be moving through your data in a way that you want to narrow your focus, one thing I can tell you is that as we've been working through our pre-implementation data with patients, it's clear to us that and providers that when people have accurate information, they're going to have different kinds of attitudes. And so because you've already assessed where people are with their knowledge about long acting, I wonder if it is possible for you to cut your data based on those who have more rather than less information, because you want to mine your data for the richest insights. And those insights are going to come from people who actually have a basis upon which they're formulating an opinion. And that's why I asked you about, what about the patients who've actually received these injections? Because for some, they're very painful and there's a lot of trepidation and they have to do a lot of psychological prepping to go and get their shots. And so anyway, there's just a lot that there's a difference in how people can present information to you as an interviewer about a topic if they're really truly grappling with it. So I would say prioritize the data that come from people who actually have a good knowledge base on long acting.
That's a great comment and suggestion. Thanks so much, Kim. It's funny that you bring that up. We definitely had that thought for the pharmacy staff members, because some who have no clue, may tend to be, either optimistic or not optimistic, have to kind of sort through the data a little bit better. Whereas persons who had more knowledge had much more detailed, I think, responses. But I didn't think about that for the patient side as well. So we'll definitely take that into consideration across all the stakeholder groups for sure. Thank you for that.
Okay, Jen, this is my actual real question that I've been waiting. And also, since Kim is on the call too, it just reminded me, I was wondering if among the clinicians, if you noticed any differences between physicians versus non-physician clinicians.
That is a really great question. We have not looked yet. So we do have a variety of physicians, nurse practitioners, mostly physicians and nurse practitioners. We have actually a couple of case managers. So those perspectives were really interesting as well, but have not yet looked. My very unscientific kind of anecdotal analysis is that I haven't seen a lot of variation in terms of differences between, for example, the physicians and the nurse practitioners. The case managers and other support staff, they just have different things that they're looking at. So I wouldn't say it's a difference of opinion, but they have different aspects that they're focusing on in terms of how they support people who might get long-acting antiretrovirals.
Thank you. Lewis also put a comment, Walgreens Community Pharmacy on 18th might be interested. Lewis, sorry, do you want to come off mute? Are they interested in working with folks to offer long-acting injectables or research?
I haven't spoken with them about that specifically, but I wonder if they would be. I used to work with them really closely, and they're the community pharmacy on 18th and Castro. It's on 18th in between Castro and Collingwood, and they see a lot of people who receive antiretroviral therapy and get it from there and have a good relationship with that patient population. And they did a lot of injections for COVID, so I wonder if they would be a good site for something like this.
You've been checking in with them to participate in this study. on another note, my understanding is what their current model is they are dispensing for strep. So they are not administering, but giving them, probably able to walk the medicines over to strep. But I wonder if at some point in the future they might consider an alternative model if strep gets really overwhelmed, particularly with, I'm thinking about PrEP for them as well.
Right. Anyone else? Any other questions?
Hi, thanks for the presentation, Jen. Yeah, Parya, I have a question. I'm thinking about, I'm clueless on this, but the coverage of pharmacies to really narrow disparities, or do we see that pharmacies really do map onto there is a disparity in location and access to, like, the distance where, people with HIV live neighborhood-wise? Is there any advantage that is there tested empirically, or is it still trying to figure that out as well?
What a fantastic question, John, as well. Something I think Parya and I are both very interested in, the idea of pharmacy deserts for these HIV services. I mean, I think there have been demonstrated to be pharmacy deserts in general, and they tend to be more in neighborhoods that house persons of color, low-income residents, et cetera. I mean, I think even locally, we've seen the closure of multiple community pharmacies right here in San Francisco. So I think there is some evidence to suggest that they are numerous. They may be less numerous or slightly less accessible in neighborhoods that may need them the most, and that the picture continues to evolve. I think post-COVID, we're seeing a new era of distribution of pharmacies that I think we're still trying to keep up with.
Thanks, Jen. We have 5 more minutes. I just wanted to ask one more question, and if other folks want to jump in. I know this is such a hard topic, but what are the models for reimbursement that could be viable? Because I know, for example, your clinic, women's HIV clinic, you all get the meds directly from the wholesaler. So there's like some cost And what, like there's like some selling back to the university there. So I'm just wondering, what are the various models that could be viable for pharmacies?
Okay, so this is a really complicated question. And I'll try my best. So it currently, one of the probably most direct models is cash payment. So, people could just simply pay for the administration services. That's, clean, it's cash, that's what it is. Pharmacies are using this model for other things. So for example, I believe it's Albertson's pharmacy that was using a cash-based payment model for COVID medication assessment. And pharmacists are able to prescribe, essentially furnish Paxlovid. So that's one potential model. I think the model that we're really trying to work towards, and that is a really huge part of pharmacy advocacy, is pharmacists being able to be reimbursed by insurance companies for their services. And there's lots of barriers to that. Pharmacists are not considered providers at the federal level. So if you're not a healthcare provider, you can't get reimbursed for services. This is sort of where the big fight is in the pharmacy community, kind of working towards this provider status. I suppose other opportunities for reimbursement, which are much more, I think, sporadic, would be, partnerships or grants with local organizations. I think we have some pharmacies that are partnering with local departments of public health to try to minimize the cost of, for example, testing or laboratory services that are needed or follow-up to kind of closely coordinate. But really, at this point, honestly, it's cash or get reimbursed through insurance. And we're working on the insurance. There was a program I think I was aware of at one point where the manufacturer itself, at least of one of the long-actings, was providing some reimbursement essentially for injection services. But I think that program has since now gone. I was looking for it and couldn't find it. I'm trying to figure out whether that could be applied to pharmacies as well. I could go on about the challenges here, but I'll just try to keep that part short.
All right. Thank you folks so much for joining today. Have a great rest of your day. And Jen, you're getting tons of love and feedback in the chat if you get a chance to look at it. Thanks, everyone. Have a great rest of your day.
Thank you, everyone. Have a good rest of your week.